Hello, everybody. Welcome back to the Incubator booth at NeoHeart 2024. We are joined now with another great speaker. We have the pleasure of having on Dr. Sujata Chakravarti from the pediatric cardiac critical care unit at NYU Langone Health. We love people from NYU. Welcome to the podcast booth.
Thanks for having us in your city. I hope you're enjoying yourselves.
So far, so good. It's a funny title of a session because it is such an overwhelming one. Case presentation format and panel discussion on esophageal atresia and tracheoesophageal fistula, congenital diaphragmatic hernia, giant omphalocele, geopolitics, world peace.
They could each be their own session.
God,
you guys are tackling.
Absolutely.
And I'm a cardiologist. When I got invited to that session, I said, oh, wow, I better study.
And it is interesting that we are maturing as a field, where we are starting to understand that, yes, esophageal atresia, CDH, we were talking to Neil Patel on a recent podcast about this interplay between heart, lungs, and so on. And we're understanding more and more the relationship between the two, which in retrospect feels like
organs are not isolated islands.
That's exactly what I was going to say. It's exactly what I was going to say. We would have figured this out sooner. And it sounds so silly now, but here we are.
That's the truth. I often say to my fellows, I'm a cardiologist first and a cardiac intensivist, but most often the most common questions I ask are about nutrition.
Yeah.
I never would have thought of it.
Right. I mean, which is what turns people away from the NICU world so often, which is that everything you've learned as a medical student is literally upside down. And it's the most frustrating. It's like less is more. And you're like, this is not what they taught me in medical school. So I completely understand. Can you share with us a little bit some of the points you're hoping to make during this session? There's a lot of pathologies that are represented here, but maybe one on something that you're going into this session and saying, I'm not leaving without saying this.
That's a great question. I think, and, reviewing this, because ultimately, I am a cardiologist, cardiac intensivist, and we do see these conditions, not infrequently. But, I think the overall point of this is that, as you said, organs are not islands. And even after a cardiac surgery, even a relatively straightforward cardiac surgery, if these other conditions exist, it impacts the patient's morbidity rate, mortality rate, length of stay. And that's, I think, the most important point that we'll probably be hearing about during these sessions.
Were any of the case presentations particularly interesting or complicated?
Well, they've actually withheld the cases from us so far, so we're going to hear
on the spot.
It's on the spot. Exactly.
What an interesting format.
Yes. I think the format is going to be, they're going to present the cases to us and ask us, if we would have done anything differently. And as you guys know, our fields are all evolving and there's not a lot of science behind a lot of the things that we do, so we're just learning as we go along. So it'll be very interesting, I think, to hear these very difficult cases.
Do you think that we're going towards a place in neonatology where when we have patients with these particular condition, taking an example of an esophageal atresia with TE fistula, right? Many times you can say, oh, heart's fine, but maybe even so, if the function is okay, we're going to reach a place where when we have these patients, it will automatically need to involve the cardiac team and just start multidisciplinary care from the get-go, not after the baby got operated on, is having a bit of pulmonary hypertension, and now we say, okay, now let's call the cardiac team.
I think I think absolutely is what we should work towards, because you can anticipate with a lot of these disease processes, whether it's T fistula where they get chronic aspiration, or if it's, giant omphalocele where they get restrictive lung disease that gives them pulmonary hypertension. I think that that's absolutely the way to go, to not be siloed, to have a multidisciplinary approach as soon as possible. I think that probably optimizes patient care and outcomes.
Yeah, and I wonder with some of these pathologies, much like we've already started to grasp with the congenital diaphragmatic hernias that the vasculature is really affected in ways that we don't quite totally understand. And I feel like the cardiologists and our cardiac critical care colleagues really have a different grasp on this concept of vasculature than I think we spend a lot of time talking about in the NICU.
We definitely talk about pulmonary vasculature a lot, and at NYU, Hassenfeld Children's Hospital, like our group of pulmonary hypertension experts are a multidisciplinary group that includes neonatologists, pulmonologists, and cardiologists, because I think all of those things are interplay with each other in the care of these patients in particular. And of course, the surgeons who are doing the diaphragmatic hernia repair.
Absolutely.
Even though you're local, are you going to get to stay for the duration of the conference, or you have clinical duties that are going to bring you right back down the streets?
No, I'm so happy to be able to stay for the whole conference.
That's awesome. Anything you're looking out for specifically during the next couple of days? Any sessions that you're really eager to listen to?
I mean, as a cardiologist, there's a focus on the final day on pulmonary vein stenosis. And that's such an unbelievably challenging field. And, even with babies with structurally normal hearts, it seems to be that pulmonary vein stenosis is more common in the premature population, especially in patients with BPD, perhaps. So it's like an interesting disease process and very challenging, and with not a ton of good treatment options, although now there are, I think, better and better treatment options with interventional cardiac approaches to managing that disease process.
Very cool.
I love that. Thank you for bringing our attention to that. I think you bring such a level of expertise to the discussion. And before we let you leave, I understand that you guys are doing some exciting things in transplant at NYU. So I'd love for you just to touch a little bit on that. We don't get to see that so much in our neonatal colleagues. So I'd love to hear just a little bit about what's new in the world of neonatal transplant.
Sure. Neonatal and, infant transplant are really exciting because that patient population, if they survive to transplant and survive the perioperative period, they have a tremendously good outcome, probably because of the immaturity of their immune system. So children that receive transplants below 1 year of age, median survival is beyond 22 years with that native transplant. And it's probably even much longer than that. And so for our patient population with complex congenital heart disease, where they're failing kind of congenital palliation, sometimes transplant's the best option for them. And we've recently done 2 young infants who both had failed stage 1 palliations, and they got heart transplants and are doing very well.
That's amazing.
So exciting.
It's amazing.
So exciting field.
Sujata, thank you so much for making the time to drop by.
It's such a pleasure.
Wish you a best rest of the conference, and good luck with that surprise session.
I appreciate it. I need it.
Bye.
Bye.